Assalamu alaikum, everyone, and welcome to the Health and Fitness Show. Today, you're joined with your host, Lamissa. I hope you all are having a very good evening, and I guess I'll get into our main topic for today. So, our show today is around understanding common vascular conditions, and we are joined by a very special guest. We've got Mr. Amir Hassan. Amir, would you like to say hi to all of our guests? I mean, all of our listeners.
Hello, listeners. My name is Amir, as Lamissa mentioned, and thanks for inviting me. I'm one of the specialty registrar working in vascular and endovascular surgery in the East of England region, and I'm quite excited to be invited here. Thank you, Lamissa.
No worries. We're very excited to have you, and we're very excited to get into the topic as well. But just very quickly, I know you touched a bit on it, but if you could kindly tell our listeners a bit more about yourself.
So, I mean, as I said, my name is Amir Hassan. I graduated from Bangladesh in 2017, then moved to UK in somewhere around 2019, and then got through the early training phases, and then got into higher specialty training in 2023 in East of England region. And so far, I've worked in sort of different areas of the country, mostly in
Mhm.
vascular surgery. And at the moment, I am in Stevenage Leicester Hospital working as a specialty registrar, and soon I'll be starting my PhD journey in Imperial College London as well.
Wow, congratulations on that. And I understand that you're a vascular trainee. What was it that kind of interested you and drew you into vascular surgery? And tell us a bit about your day-to-day role as a vascular registrar.
That's a very good question. I mean, that is actually a question that is asked in the ST3 interview as well, why to choose this
Oh.
specialty. So, I mean, I had a couple of reasons, obviously. If I think about from a clinical point of view, in
Mhm.
vascular surgery, we need a wide range of surgical skills. For an example, a first case is probably an above knee amputation where you're basically chopping off the leg, where you can work with big knife and things like that. And probably the next case is a making a fistula, which is you work in a 4x4 box where you can barely move your fingers only.
I
So that's
see.
wide range of surgical skills, and then we see patients from different ages and with many comorbidities. That was one of the main reasons for me to choose vascular surgery, as I always wanted to do some sort of surgery which is close to medicine, where you get your
Mm.
medicine knowledge brushed up as well. So that was a major reason for me to choose vascular surgery. And when I started vascular surgery, I saw it is an evolving specialty with newer
Okay.
techniques coming in and lots of research happening. So this is a very happening specialty, I think. That's the reason I chose vascular surgery. And in answer to your
Wow.
second question, day-to-day role as a
Mm.
registrar, that really depends. One set is your on call when you deal with the emergencies, deal with the emergency surgeries, and take referrals from other specialties and other hospitals.
Yeah.
And the other days, either you're doing a clinic where you see outpatients in your clinic, sort of 10 to 15 patients on a 4 hour slot. And then if you're in theaters, then you're just operating for the whole day. So that's how a day to day looks like for me.
Good. So I guess quite a range in the day and types of shifts, but also kind of a range within the specialty as well, which kind of drew
Yeah.
you to it. Wow. Um, wow, that's amazing to hear, and it's amazing to, get a bit of a insight into what you get up to day. I guess vascular, as a person who's in medicine, vascular seems like such a, difficult but
Yeah.
also scary specialty in a way. So yeah, it's crazy to see someone who does it day to day, if that makes sense. Kind of in
No, we're
awe.
the friendly, we call ourselves friendly, fancy plumbers.
Ah, I see.
Yeah.
Oh, wow. Okay, so what we're going to do is we're going to be getting into kind of the nitty gritty, I guess, of your specialty and trying to break it down to our listeners.
Mhm.
But yeah, I guess we'll start off with the basics first of all. For those who may not know, what is our vascular system? And I guess you kind of alluded to it in the sense of calling yourselves plumbers. But I'll let you kind of expand a bit more about that.
So, vascular surgery is all about the vascular system. Now, the vascular system is basically, in simpler word, it's plumbing. It's your transportation or water system in your house, like in your body as well. The arteries that take blood from the heart and then takes it to different parts of the body. And then there is another set of circulation system, which is called the veins. The veins, they collect blood from the organs and from your limbs, and they bring it to heart for purification and filtration.
Mm-hmm.
So what we do, or what vascular involves, is um, if there is any blockage, if there is any tear, if there is any problem in your plumbing system, then you call us. Then we come and we fix it, essentially.
Yeah, that is a way of making us all kind of get what it is. So that's great. Thank you for breaking that down. And in terms of kind of today, we're going to be discussing kind of common vascular conditions. So, what are some of the common vascular conditions that you encounter, and which are the ones that we'll be discussing today?
So the most common vascular condition that we deal with day to day is PAD, which is basically peripheral arterial disease, which normally affects the lower limbs, which are the legs. Okay, and so that's one. Second is obviously aneurysms are there. Aneurysms can be there in any part of your body. Mostly we deal with the aorta, which is the main pipe coming out of the heart. It can Aneurysm is basically bulging up of the artery. That can happen in any part of that tract all the way to your leg. So we deal with that. Third thing we deal with is something called carotid artery disease, which is basically the artery that supplies your brain, and any stroke can be caused by narrowing of that artery. So we deal with that. And then comes to the venous section, where something called varicose veins and deep venous thrombosis. And obviously, we deal with lots of leg ulcers. And now, leg ulcers can be of varied reasons, can be because of arterial problems, can be because of venous problems as well. And also, we do in many centers, it is a shared subspecialty, which is basically creating a fistula between your artery and vein in order to be able to do dialysis through that channel.
Yeah. So hopefully we'll cover loads of those conditions today and get a good broad understanding. So we'll start off with peripheral arterial disease, which you said is one of the most common conditions that you kind of encounter. So what is it, if you were to give a breakdown? How does it develop as well?
So peripheral arterial disease, it's basically happens in the peripheral arteries. It mostly affects the limbs, and more than the arms, it's the legs which gets affected. There's also because of the gravity there as well. So that's at least 1 in 5 people in United Kingdom gets some form of PAD, peripheral arterial disease.
Okay.
That might not be symptomatic, that might be symptomatic. So if we break it down to peripheral arterial disease, it can be classified into two sections. So one is acute limb ischemia, and another is critical limb threatening ischemia. So acute limb ischemia, obviously acute means sudden, and limb ischemia means your limb is cut off from blood supply. So that is essentially a sudden cut off of blood supply to your limb, which is causing threat to the limb viability. Now, acute limb ischemia can be caused from many reasons, but the most common or the main pathology is an embolus, is a blood clot. It can come from the heart, it can come from any other place of your body. It just gets stuck to one of the arteries and blocks the blood to go downhill. So that's, in simple terms, that is acute limb ischemia. The more we see, the more pathology we see is called critical limb threatening ischemia, which is basically chronic buildup of atherosclerotic plaque, which is basically grease, fat, and calcium, exactly
Mm.
like the pipes in the kitchen, right? So then
Yeah.
it just narrows the pipe, so there is chronic limitation of blood supply going to your legs, causing gangrene of the toes, and then causing different kind of ulcers, which is not healing, and then end up, um, killing the leg.
Okay.
If we think about the risk factors of it, so
Yeah.
if I talk about acute limb ischemia, that can happen to anyone. That is sudden, and the only cause for that is a blood clot. Now, in general terms, blood clot can come from your heart if you have a condition called atrial fibrillation, which is basically
Hmm.
your heartbeat is irregular, then your heart is pumping irregularly, and then that can produce some clot, which can then shower off and block one of the pipes downhill.
Yeah.
Okay, so that's one reason. Second of all is if you have got thick bloods than normal people, that can be from many reasons. If you have a, you know, occult cancer, if you have a cancer which is hidden, not diagnosed, and if you had any hematological disorders or blood disorders or any genetic disorders that makes you more prone to have clotty blood or thick blood, then you're
Hmm.
prone to make more blood clots, and that can shower off at any point in any part of your limbs. But mostly it affects the lower limbs because that's the way gravity works as well. Okay. Then in terms of critical limb threatening ischemia, that is the
Hmm.
major chunk of our work. I would probably say 80% of our arterial work is critical limb threatening ischemia. The main risk factors for it is smoking and diabetes. These are the two of the biggest risk factors. And if you see geographically as well,
Hmm.
in South Asian population, diabetes is very common, and smoking is unfortunately is the rate is increasing as well. So both
Hmm.
the combination is a deadly combination for your limbs.
Yeah.
Not only for your limbs, actually, it increases the risk of heart attack, stroke, and limb ischemias as well. But what happens is, if you have a heart attack or a stroke, that is very evident. You get the symptoms and you can get it treated. But for the leg arteries, for peripheral arterial disease, it can remain silent for many, many years until the day
Hmm.
comes when the artery is so clogged that no blood can pass through. Then you start getting aches in your leg. How it starts is you always it always starts, there is a pattern of it, right? So it always starts like, okay, say for an example, I walk a mile without any problem in my leg. Then
Yeah.
suddenly you walk 500 meters, then you start having pain in your calf muscles.
Hmm.
Usually, you take a bit of rest for a few minutes or so, it gets better, then you move on with your life. Many people,
Yeah.
many people don't, seek medical attention at that point. They're like, yeah, it is normal. Then what happens is the next step is basically you start getting pain with shorter distances. It comes to 200 yards, then 100 yards, then less than 50 yards. Then you start getting pain even when you are at rest. You can't
Okay.
keep your foot on the bed. You can't, you just keep your foot down because hanging, the gravity works, and that helps, that helps the pain, to go away for a bit. But that again is a deadly combination because then all the fluids in the body is accumulating in the leg, and the leg becomes very swollen. So when the leg is swollen, if you
Yeah.
think about it as a box where it should be only muscle, some vessels, and bones, now there is a lot of fluid. Where is this fluid going to go? This is going to cause pressure on the skin. Then you'll start having skin breaks. That skin breaks in
Mm.
medical terms is called ulcer. And when you have an ulcer in your leg, It needs more blood to heal it, but it won't be healed, okay, because you don't
Yeah.
have enough blood. All right. So then there is skin breakage. When you have a skin breakage or an ulcer, obviously it needs more oxygen and more blood to heal it. But
Yeah.
be, because your arteries are clogged, that's why not much blood, not enough blood is going down to the wound to be healed. That's where all the problem starts. The irony is people only come to us when there is an ulcer. We're trying our best to make people aware of the fact that when you start getting pain unusually short
Mm.
distance, that is the time you need to come to us. Because if you come to us at
Mm.
that point, lifestyle modification and some medication can prevent further problems. Because when there
Okay.
is an ulcer, that's already the last stage of the disease. At that point, we can improve blood supply in order for that wound to heal, in order to save your leg essentially. But your leg
Yeah.
is not going to be the same as it was before. So
Yeah.
that's where critical limb threatening ischemia is. That's where it is. Okay, so
Yeah.
that's the biggest problem we have. And also,
Mm.
people with diabetes, they do have peripheral neuropathy. So that means their nerves are damaged. So they can't feel it. So many of the time, they can't feel their legs properly. So they don't know if it's too cold or too hot. Sometimes they get
Right.
pinprick, sometimes they get nail prick, or like simple erosion from the shoes,
Yeah.
and they can't feel it. They can't look into their foot. They don't look into their foot, and the foot has got, because of diabetes and chronic smoking, your arteries
Yeah.
are clogged, not much blood is going. So this is like a vicious cycle. Once the cycle starts,
Mm.
you have to break the cycle at the very beginning. If it
Yeah.
starts going round the circle, you won't be able to come out of the cycle, unfortunately.
And that's why I guess knowing the signs, like you said, as soon as you start walking and you notice that your legs are aching, things like that, is very important information so that people can be aware of when to actually go and seek help. Because I feel like a lot of us, like even you and me, might put smaller things down and be like, oh, it's okay, it'll get better on its own, things like that. People
Yeah.
have a tendency to do that. But actually being aware of the risk factors and being aware of the signs, just like you said, can help you come in at that early point where you can actually make the most benefit through lifestyle measures, etc. But thank you for breaking all of that down for us, and talking a bit about the common kind of signs and symptoms. Um, and you said that there are some surgical management. What perhaps when it gets to that point, do you mind talking about the different stages of management that people might have for peripheral arterial disease?
Yeah, for sure. So when you start getting pain after, say, a certain amount of distance, let's say 500 yards or like, a mile or something, at that point, that means your arteries are already starts getting some calcifications. So that's called sort of the first stage of the disease. At that point, if you come to us or if you even go to the GP, the thing would be lifestyle modification. When we say lifestyle modification, that means if you're diabetic, you need to have a proper diabetic control. Okay. If you're
Yeah,
smoking, you need to stop smoking. I know I'm very much aware that is easier said than done, but
yeah,
smoking is the biggest risk factor for peripheral arterial disease. So if someone is a smoker, they need to stop smoking completely. And that is the time to do it. Okay. Because the end point is you end up losing your leg if you don't do so. Okay, I'll explain that in a moment as well. So that's sort of the first stage of treatment. And then also we give some medication. We give a single antiplatelet to keep the blood a bit thin, and then we also give something called atorvastatin, which we know that it lowers the cholesterol, but we don't give it for cholesterol lowering reasons. We give it for its another property, which is basically reducing the inflammation inside the artery. So what happens is because the arteries, if they start getting foreign bodies in it, the arteries gets angrier. That is inflammation, right? So if you can reduce the inflammation, then the plaque or the calcification, they get stuck to the wall. so they can't shoot off and block any artery. So these are like secondary prevention medication, but the key here is lifestyle modification. Control the diabetes, control your weight, stop smoking, and keep walking. So that's basically the first line of management.
Yeah.
When you reach at a stage that your lifestyle modification is not improving your symptoms, you start having something called rest pain. At that point, we do scans to figure out what sort of management that you need, because we've got different techniques to deal with it. Okay, so in general, surgical options are sort of endovascular, and endovascular means keyhole surgery and open surgery. So keyhole surgery is basically essentially going into the artery with some wires and balloons and try to stretch up the artery to make it open. Sometimes we put some stent to keep the artery stretched. Okay, so that's called angioplasty. So that is usually done as a first line of surgical management to see, minimally invasive surgery. But obviously that depends on what sort of lesion it is, where the problem is, and how long the occlusion or the stenosis is. Then the next bit of management is a bypass surgery. It is essentially your pipe is blocked, so we need to, take your vein out of your leg or use a plastic pipe to make a bypass road. So that bypass can go from, any place to any place, essentially. We just need to find healthy bit of artery to take the blood from, and then channel it towards, the healthy part of artery where you need it in your legs. So that's essentially the main treatment of peripheral artery disease.
Wow. Okay. I mean, that is just the idea of that type of surgery is just kind of insane in a way, isn't it? The fact that you can take an artery or a vein from somewhere else in the body and then use it to bypass another area. Very, very interesting. But I guess at that stage, it means that a patient's condition has gotten to quite a point where, they're not able to use their existing, I guess, plumbing system. And so we have to put somewhat of a new one in place.
Yeah, because the existing plumbing system is blocked, and it is causing the leg, causing the leg's life, essentially. So we do limb saving surgery. So the bypass operation is practically a limb saving when nothing else is working in your existing plumbing system. So you need a new plumbing system. So that's what we do.
Yeah, wow, that's amazing stuff. But I guess thank you for explaining peripheral arterial disease and actually going into the signs and symptoms and the risk factors so clearly. I guess one of the main kind of messages that I got from this first half is smoking is definitely bad for your health. And trying to stay on top of and managing your diabetes as well as you can really help prevent these other complications. I guess we don't realize that diabetes itself isn't just one condition and can actually lead to other worsening aspects of our health, and so it's important that one thing we kind of control it. But
we call diabetes as a gateway disease. It just opens the gate for many other disease to come in, unfortunately.
Unfortunately, very, very true. And it is something that is quite prevalent within our kind of community, and so it's important that we try our best to try and raise awareness about it and the fact that it is that kind of gateway disease. But thank you so much for explaining it all. And this does bring us to the end of the first half of our show. So inshallah, we'll join you all after the break to discuss a few more of the conditions that we talked about. Please do stay after the break and we'll see you then. Assalamu alaikum wa rahmatullahi wa barakatuh.
Get Luton prayer and Jamaat times for your local masjid on your phone. Download the Inspire FM app. Available for free on the App Store or Google Play.
Assalamu alaikum everyone and welcome back to the Health and Fitness Show. This is the second half of our programme this evening. In the first half, we essentially discussed our main topic, understanding common vascular conditions, and we basically went over peripheral arterial disease and the main kind of risk factors and management points of that. We're joined by our guest today, Amia Ahsan. Thank you very much for joining us today. And I guess we'll go straight back into the topic. So we'll be talking about coronary artery disease and stroke risk now. So how do problems in the kind of neck arteries lead to stroke?
Right. Welcome back, listeners. So it's carotid arteries. So there are two carotid arteries on both sides of the neck that supplies the brain, different parts of the brain, obviously. So this internal carotid artery, which goes to the brain, again, the similar mechanism, the pipe, it's a pipe, it gets clogged, it gets narrowed with plaques, with greases, with fats, and that again impedes blood supply to certain part of the brain. Now, what that manifests as is stroke. So when someone gets a stroke or a mini stroke, like a transient ischemic attack, so that stroke can be because of two reasons. One is bleed in the brain, but that's not the most common. The most common is called ischemic stroke, which is basically part of your brain has got less blood supply than what it is needed. Similarly, like a leg. So you start seeing blackening of your toes. So it's basically part of your brain dies. That's where the symptom comes from. Sometimes the symptom comes as something called cartane coming down of your one eye and causing temporary blindness for a while, or you can have a major stroke and gets paralyzed on one side. So this is all caused by the narrowing of the neck arteries. Now, in terms of managing that, how I mean, obviously it is primarily managed by the medical doctors, the stroke physicians, but then we come as an adjunct specialty in it, because the evidence shows that if the stroke is because of the narrowing of the carotid artery, then doing a surgery can reduce the risk of further stroke up to 80% from that side. But many people do not understand the fact that it is not a curative surgery. So if you had a mini stroke or a stroke that has sort of left you with left arm paralysis of some description, that's not going to come back from a carotid artery surgery. What we do is to prevent further major stroke from that side. So that's where we come in, but it is primarily managed by the medicine and medical team. And there is debate about it, like, should we do carotid surgery? Should we not do carotid surgery? Obviously, there are technical challenges, and there are some technical guidelines as well that we need to follow in terms of what is the severity of the tightness of your carotid artery. For an example, if it's less than 50%, we don't get involved in it. 50 to 99, that's when we get involved, because it says moderate to severe stenosis, you can reduce the risk of stroke. The reduction rate is greater than you can achieve with medicine. That's what the current evidence say. That's when we offer carotid endarterectomy, which is basically making a cut in the neck, get into the artery, clear the plaque out, and basically patch it up. So what we patch it up is with a patch which is made of baby cow's heart covering. So it's called bovine pericardium. So that's what we sew it up with, so to keep the artery nice and healthy and patent.
Okay, that's very interesting. Thank you for going into that. And I guess, what is your kind of number one advice that you would give to listeners about keeping their arteries healthy? I know we talked about kind of not smoking, and kind of getting their diabetes under control. Is there any further advice that you would offer?
No, it's generally, I mean, for your heart doctor will tell you the same thing. Your medic will tell you the same thing. Is if you keep your diabetes under control, if you don't smoke, your arteries are going to be healthy. It's the same artery that the cardiothoracic surgeons work with. They only work in the heart and lungs. We work in the rest of the body, but it's the same artery. So the advice is same, and the pathology is pretty much the same as well. Yes, the treatment varies, but the pathology is the same. There is buildup of foreign body, which should not be there, is causing narrowing of your artery.
Okay. And I guess we will move on to discussing aneurysms. So a lot of our listeners may have heard about aneurysms. We're not entirely
Yeah.
sure about what it is in particular. So what is an aneurysm, especially our AAAs or abdominal aortic aneurysms?
Yeah. So aneurysm basically means bulging up of the artery. Now, when the artery bulged up at least 1.5 times more than the normal size. For an example, an abdominal abdominal aorta is roughly 2 to 2.5 centimeters for normal people anyway. So if it goes above 3.5 centimeters, then we start calling it as an aneurysm. But we only treat aneurysm when it reaches a threshold. The national threshold at the moment is 5.5 to 6 centimeters, and there is a
Okay.
nice screening program
Mm.
in this country where they basically screen with an ultrasound scan. Every male 65 or above gets a scan. If the aorta is bulged up to a certain degree, then they
Yeah.
get further surveillance once a year or 6 monthly, and when it reaches the threshold, they come see us in the clinic, and then we take it from there. But probably the one good thing about South Asian community is we don't have it. We don't get aortic aneurysms as much
I
as you
see.
as you will see in Western ethnic origins. Okay, so
Okay.
South
Why is
Asians.
that?
So this is still a mystery that's got something to
Mm.
do with the genetics, okay? Because these arteries bulge up because arteries has got couple of layers, and all the layers are, you know, strengthened by collagen, right? So it's like in the bone as well, right? So
Hmm.
if someone has got problem with the collagen disease, or it's called collagen disease, then your collagen is weaker. That means your wall of the arteries are weaker. Then because of the swelling blood inside and the force of it, the artery gets bigger and bigger. But
Right.
as a geographical variation, we don't see that much of South Asian people coming with triple A's. It's sort of negligible at the moment. We can say probably less than 1%. But whoever I've seen so far from South Asian community coming with an aneurysm, they have a family history of aneurysm, and they have some sort of collagen vascular disease in them. So that's more to
Right.
do with genetic predisposition rather than
Yeah.
anything else. But as a ethnicity, we don't see that much of aneurysms in our ethnicity.
That's very interesting to know. Okay, and I guess that kind of wraps up our discussion about the kind of arterial side of the plumbing within us. And we're now going to move on to discuss kind of the venous side of things.
Mhm.
So yeah, uh, I want to start off by talking about kind of varicose veins and chronic venous insufficiency. So many people do notice kind of varicose veins. Are they just something that is cosmetically can be an issue for people, or is it something that can develop into something more serious?
Right. So before we get into that, so we just need to understand the basic venous anatomy. So what we
Hmm.
have in our body is two sets of veins. So one set is called deep venous system.
Okay.
They do the same thing, but there are two sets of system in it. One is deep venous system, which is very close to the artery, so you can imagine that is deeper in the body. And
Yeah.
then the other bit is the superficial veins, superficial venous system. So those superficial venous system, all the veins have got a valve in it. That means because it has to work against the gravity. That means if you can imagine, blood has to come from your toe towards your heart. So it has to work against the gravity. That is why the vein is created such a way it has got valves or one-way trapdoors. So blood can only come from distal towards the heart. It cannot go other way around. But
Hmm.
as people grow older, as you lose elasticity of the skin, so some of the valves starts breaking down. They don't work as properly as it would work in a normal person. Okay, so when that happens, that means some blood starts going back. that causes pressure in that tiny vein. That's when you see the bulged up, wiggly kind of vein, which is very visible outside. So that's called varicose vein. And so if you have venous insufficiency, that causes varicose veins. Now, varicose veins, again, it varies. Okay, does it require treatment? Not always. Not always it requires treatment. If you only see some tiny little veins in your legs at the end of the day, that means you probably are developing some form of venous insufficiency, but you do not need to be worried as of now. Simple techniques like at the end, if you have a job which requires you to stand for a longer period of time, so whenever you get time to sit, you keep your leg elevated so you can drain the fluids, you can drain everything. Okay. So that's
sense.
one. Second is the second line of treatment that we do is if your artery supply is good, then we give compression stockings or flight socks. You can buy it from Amazon or Boots or anywhere. Okay. So that also, because if you have a job that requires you in a long time standing, it is advisable that you wear a flight sock or a compression stocking to prevent varicose vein. And you'd be surprised to know many of us, including myself, when we go for an operation that would take us more than 4 hours, I wear compression stockings on both my legs. I don't have any signs of varicose veins, but just to prevent. Okay. And also the other advice we give people above 30 is try to use a flight sock if you are flying for a longer period of time, because that prevents DVT, which we will talk about it a bit later on as well. So then obviously varicose veins then comes as an entity. First one is you see some veins, okay, then it starts affecting the skin. You see some discoloration of the skin and your leg gets very swollen. Again, the same mechanism. The leg is swollen, it causes stretching of the skin, then you start seeing breakage in the skin, and then it causes ulcer. But this time, the ulcer is not caused by your arteries. That is caused by your veins getting bigger and getting more, tense. Okay. So when do we treat varicose vein? That is a very debatable question. Okay. Now, someone might want to have those varicose veins taken out for cosmetic reasons. We don't really offer that in NHS. We don't have funding for that in NHS, but people can get it done privately for cosmetic reasons. But if it is symptomatic, when I say symptomatic, that means your leg is heavily swollen, your leg is aching at the end of the day, and you start seeing some discoloration of the skin, okay, which is called basically pigment deposition. Some various pigments deposit in the skin, then the skin looks a bit darker than your rest of the body shades. That is the time we start offering treatment. Obviously, if you have an ulcer, you need to have treatment for that, for the ulcer to heal. Okay. So again, as a pathology, ulcer can be very misleading. Because on our previous half of the show we discussed about arterial ulcer, that you need more blood. You need more blood for that ulcer to heal. Now with venous ulcer, we want to take the hypertension or the tension from the vein. That means we're essentially limiting blood going or draining from that ulcer for it to heal. So that can be very confusing. And that again is part and parcel of our on calls, because obviously people in the community or the GP, they do not have that much of an training or an experience. Second of all, they don't have the logistics to figure out if that is an arterial ulcer or a venous ulcer. So our ulcers can be very misleading sometimes or confusing as well. Okay, as medics always say that fever is basically mirror of your internal body system, We vascular surgeons, we say ulcer tells us something. Every ulcer has a story to us. We can look at an ulcer, examine and figure out, even from the location of the ulcer, we can tell if it's caused by the venous system or caused by arterial problem, or it is a mixed nature. Okay.
Right.
Coming to varicose vein treatment, right? So how do we treat varicose vein? Now this is again evolving. Okay, many
Yeah.
years back, there used to be a thing called high tie and stripping of the vein, which is basically making a cut in the groin, find the junction where the superficial vein joins the deep venous system, and tie the superficial venous system completely and take it out. Okay.
Oh, okay.
Nowadays, newer techniques have arrived, something called endovenous ablation, which is basically, I mean, it might sound very fancy, but it is basically burning the vein from inside. Yeah,
Okay.
it's an again keyhole surgery, minor procedure. We do it as an office procedure. We pass a rod in the vein and burn the vein from inside. So essentially,
Okay.
we're burning the vein. So that vein is not working anyway. So we essentially burn the vein. So it shouldn't cause any further problem. Then you can do it with laser as well. And there is some other techniques called foam sclerotherapy, where we inject some burning material, as I meant, in the form of foam, into the vein which is causing problem. So that's very targeted. If you have a small ulcer which is being fed by one little vein, we can block the vein like that. So that's how we treat varicose vein. But the mainstay of treatment, even after we do all this procedure, is to carry on wearing the compression stockings.
So that's our kind of mainstay, which is awesome.
Yes, and if you think about our part of the world, because it's very hot and humid, people there do not wear compression stockings. I have got family members which they have been treated for venous problems, but because of the humid weather and they don't want to wear it because it is tight, it's not comfortable, they don't wear the stockings, it's going to come back. There is 5 to 10% recurrence of varicose veins even after treating.
Okay, I see. So wear your compression stockings is the mainstay of kind
yes,
of
if your arteries are good,
preventative
then wear
advice.
compression stockings.
Yeah, perfect. Okay, and now we're going to move on to deep vein thrombosis, which you kind of alluded to a bit earlier. So what does deep vein thrombosis mean? What is it, and how does it form?
So a deep vein thrombosis is basically clot in the deep venous system. As we discussed earlier, we've got superficial venous system and deep venous system. Now you can have clot in the superficial vein as well, but we're not worried about that much, because the reason for that is, we're worried if anatomically it is in a certain position, but for superficial vein clots, we're not that worried as we are worried for deep venous clots, because that deep venous clot, it usually occurs in the leg. But if you remember, all these veins goes to the heart, and they go to heart via lungs as well. So these clot in the vein, they are the troublemakers, because they can shoot up to the heart, can cause a heart attack. They can shoot up to the lung, that can cause a pulmonary embolus. And if that clot is very naughty, that can even go via your neck vessels and cause a stroke. So that is why deep venous thrombosis, aka DVT, is an emergency. Okay. So why the clot develops? Again, no one really knows why the clot develops. There are hundreds of reasons for your body to produce a clot. Your body can produce a clot for many reasons. Then you can present as a DVT. And interestingly, or very sadly, we see a lot of patients who presents with a DVT or a clot in the artery. Okay, so either clot in the artery or the vein. Then we start digging around why the clot is there. Then we find some cancer which has been undiagnosed. Okay, so there is a common myth that if you have a cancer, you'll see weight loss, you'll have a lump and bump, and all sorts of prodromal features. But these days, there are many, many, many silent cancers, and many of those patients presents primarily as a DVT or a clot in the artery. Then we have a term amongst ourselves called clot hunting business, which is basically we deal with the clot problem, we deal with the medical main emergency problem, then we have to find out where the clot is coming from. Otherwise, it's going to keep on showering clot. Then when we're doing that, we find out, oh, he has got a cancer or she has got a cancer.
Fine. So it can often be one of those earlier signs.
Because if you have a cancer in your body, that automatically makes you prothrombotic. That means your blood is thicker than normal people, so you are prone to get blood clots.
Fine.
But there are other reasons for DVT as well. Long haul of flight. If you're doing a long flight, that can have an unprovoked DVT. For younger women, if they are on contraceptive pill, some of the pills can increase the risk of DVT as well. So there are other reasons, but cancer is one of the reasons.
Fine. And what are the common kind of warning signs or symptoms of a DVT that people it would be useful to know about?
So signs of DVTs are very simple. It basically suddenly your one leg will be swollen. You get sudden unilateral swelling of a leg. It gets very painful. It gets very heavy. You can't move it. And in the extreme situation, your arteries are getting compressed because of the clot in the vein as well. So you start getting, tingling, you start getting cold feet, you start looking at your foot, it looks, first purplish, or it can even look white. If it looks white, that means your arteries are compromised as well. So that is a surgical emergency. Okay. But 90% of the deep venous thrombosis presents with leg swelling and calf tenderness or thigh tenderness.
Fine. Thank you so much for breaking that down. We are coming to the end of the show, actually, which is, the show's gone by very fast. Just very quickly before we do wrap up, what is a kind of real world case or a patient story that you can share where a patient's outcome was dramatically improved thanks to kind of vascular intervention?
So actually, I was on call the night before last night. So I got a call from one of the hospitals, which is roughly 45 miles away from the hospital I work in. They had a patient, I think he was in his 60s. Okay. They started having horrible tummy pain going to the back. They did all sorts of scan. Then I asked for a CT scan, and he found to have a ruptured aortic aneurysm. So that means the aorta has ruptured, has burst, and it is bleeding. He's bleeding inside. He started dropping his, blood pressure. He started becoming very unwell. So we got him as a blue light transfer. He was not fit for any general anesthesia because his heart was not good and all of it. So then we took him to theater. We did endovascular repair of the aorta under local anesthesia, and he's alive. He's in ITU, but he's making good progress. So that was sort of a satisfying midnight case. Really.
It must be, so I guess in a way rewarding to have that type of effect through the work that you do. Okay, so that does bring us to the end of the show. Thank you so much, Mr. Assam, for joining us today and giving us your time, but also taking the time to kind of break these conditions down and raising awareness generally about vascular health and how we can kind of take ownership, I guess, in that sense of our vascular health and make sure we stay healthy. Is there anything lastly that you'd like to say to our listeners just before we leave?
Well, thank you, Lamissa. and you have been an amazing host. And thank you, Inspire FM, for inviting me. Last but not the least is just do not smoke. Who is smoking? This is the right time to stop smoking. Please stop smoking. Keep walking, and keep your diabetes under control. If you have it, if you haven't, fantastic. And if you don't see a vascular surgeon in your lifespan, you're one of the lucky ones.
Very, very true. Thank you all so much for listening to today's show. We wish you a great evening, and thank you, Mr. Hassan, once again for coming to join us
Thank
today.
you so much.
We'll see you next time, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.